Thanks for coming, everyone. On behalf of Captain Scott Goldstein, I welcome you to Pikesville and for the EMS training. I super appreciate your time. My name's Sean Barinholtz. For those who I haven't met, I'm an anesthesiologist, critical care physician at Hopkins, and a volunteer here at Pikesville. I also service on behalf of Andy Pollack in the medical director's office, myself, Jeff Sagal, who's back there, Dave Wittberg in particular, in the medical director's office, is very committed to try to provide some EMS training for our community. So thank you again for coming and for supporting this. If you have any other ideas on how to expand, please let me know. Today, we're so thankful. Rosalyn Berkowitz, thank you so much. Rosalyn is a forensic nurse examiner at GBMC. She's on the board of the Maryland Healthcare Coalition Against Domestic Violence, a member at large on the Baltimore County Domestic Violence Fatality Review Board. Rosalyn has 18 years of nursing experience, 2 in the ICU, 14 in the ED. She's worked as a forensic investigator for the Office of the Chief Medical Examiner in Baltimore for 9 years performing death investigation. She worked with the Domestic Violence Program at Northwest Hospital for 7 years, worked on the Strangulation Response Project, the Forensic Light Source Project, taking call for the Lethality Line, and assisting in the training of many providers. I've also learned that Rosalyn is a passionate educator. So for that and your generosity, I super thank you for being here and for sharing. Let me step into you. Sure, can I help you? You sure can. Great. And maybe that pocket, or?
I don't have a pocket.
I'm sorry.
I guess I'll have to stand by the... Okay. And with me tonight is Valerie Weir, who is one of our forensic nurse examiners at GBMC as well. So we have some objectives tonight. We want to recognize the prevalence of strangulation, understand the potential lethality of strangulation. We want to identify signs and symptoms of near-fatal strangulation that may be missed, easily missed, and understand the impact of trauma to the brain as it relates to patient behaviors. So I'd like to start each presentation with the pictures of these 2 women, because these 2 women in California were really the beginning of research on strangulation that is non-fatal strangulation. Prior to this, the majority of the research was done on victims of strangulation that have died. So they were post-mortem studies. The lady on the left is Cassandra Stewart, and in 1995, she called the police because she was strangled by the father of the baby that she's holding on her lap. And when the police got there and EMS got there, like many domestic violence victims do, she recanted. And she decided to be evaluated. Notes were taken of the injuries to her neck. 2 weeks later, she was stabbed to death multiple times in front of her friends. The lady on the right, Tamara Smith, was found in a field. She had been strangled and was set on fire, and EMS found her. She was strangled by the father of her baby, and she was also 5.5 months pregnant at the time. So he was found guilty of 2 counts of homicide. After these deaths, the San Diego City Attorney's Office did a study into these deaths, sort of like an informal fatality review board. And they've had a lot of findings, and what they did was publish them in the 2001 Journal of Emergency Medicine. After that, they developed the Training Institute on Strangulation Prevention, which is, they have an amazing week-long training just on strangulation. They talk about the investigation, the prosecution, the medical piece of it as well. And that was implemented in 2011. In 2013, I had. So what's the significance and prevalence of strangulation? Why is it important? It's one of the most lethal forms of violence. Everybody minimizes it. Victims minimize it. They say, I'm fine. There's nothing wrong with me. I had a lady come into the ER who was assaulted by her boyfriend and strangled. She came in, she had a fractured orbit, and all she was concerned about was the pain of the fractured orbit. We did a CTA, a CAT scan with a dye injection so you could see the blood vessels leading to the brain. She had a carotid dissection as a result of being strangled. And she said to me, it's no big deal because my boyfriend does this to me every day or every other day, and I'm fine. And I said, but you might not be fine this time had you not come in to be evaluated. You could have a severely debilitating stroke months, days to months down the road, even up to a year. Abusers often minimize it, and they preemptively call 911 to set up their defense. So you have a victim who has just suffered an anoxic event. She's confused. She might be agitated. And the person that called 911 is sitting there, and he's very calm. And he might have injuries on him where she may not. And that's because if somebody is strangling you, you're going to do your best to get away from them. I had a lady that finally was able to grab a knife on the countertop and stab him like that. Well, she got arrested until we had it straightened out as to who was the predominant aggressor. The police are much better at this now than when we first started this journey. Police also minimized it because they didn't know anything about it. They had no training as to what can happen. Same thing with medical. I remember my first patient I saw in the ER when I started looking at this research, and the attending physician came in and said, well, you were strangled. Let me feel your neck. Okay, you're fine, but you're hoarse. It sounds like you have a viral pharyngitis. So go home, drink lots of fluids, and take some ibuprofen, and you'll be better in a few days. We now know that this is one of the symptoms of strangulation. EMS, without training, would minimize it, and patients would all the time, not being asked the questions, sign an AMA and stay home. Hopefully they all survived. The problem is there is insufficient cause for arrest or conviction due to lack of visible injury. And we'll talk a little bit more about that, about one of the studies. And it's often treated as a misdemeanor. 48 states have strangulation on the felony statute. Maryland is not one of them. We've tried multiple times, and we haven't gotten anywhere. The only time strangulation is a felony is in the context of a sexual assault in Maryland.
What's the other state?
I don't know. I don't know. So this is an example. It's a 911 tape of the type of thing that happened before we started doing training.
Is she an ambulance? No, I like that.
First of all, she's pregnant. We do know that domestic violence increases during pregnancy. And it is one of the high reasons of homicide in pregnant and recently pregnant women. The other thing is they totally downplayed the strangulation. This is the kind of thing that happened prior to education rolling out about the lethality of strangulation. So there was a study done by Glass et al., and one of the researchers was Jackie Campbell from Hopkins. And what they found is that victims of prior non-fatal strangulation are 7 times more likely of becoming a homicide victim. They're 750% more likely to be murdered at the hands of the same partner. And we already discussed, 48 states have passed laws making it a felony. What's the prevalence of strangulation? 10% of violent deaths are from strangulation. Anywhere from 12 to 20% of sexual assaults include strangulation. In 50% of the cases, children were present. 99% of the perpetrators are male, and about 98% of the victims are female. But I think this number is probably not an accurate number, because if you think about it, any of the guys in this room, if your wife strangled you or your girlfriend strangled you, are you going to go to the hospital and tell them? So I think it's an area that is probably underreported. 90% of them have a history of domestic violence, so it's rarely the first thing that happens. It's an escalating relationship that builds up to strangulation, usually. Depending upon what study you look at, as high as 68% of domestic violence have been strangled. This was a study of shelter clients, and they're high-risk patients, high-risk clients anyway. And one of the things that really brings seek protective orders is strangulation. So at GBMC, we started in 2013, we had 5 to work on a protocol to be medically evaluated in the emergency department for strangulation. In 2014, we had 1 case, and that's really when we implemented the protocol. In April of 2015, we started, our forensic nurses are on call to come in and do evaluations on strangulation victims. They do thorough assessments, they do documentation, and we also do use an alternate light source, and we'll talk a little bit more about that later. So that year, we saw 25 cases. The following year, we saw 50. Last year, we saw 69 cases of strangulation. 15 of them were with sexual assaults. Now, I think the jump in the sexual assaults is initially we probably weren't asking our sexual assault patients had they been strangled. And we started asking that on a regular basis, and we found more. And these weren't strangled for autoerotic type stuff. These were strangled for power and control. There's a difference. This is just a graph. We had to do a lot of education. We have a grant with involved cases of strangulation. So what we do is for the purpose of prosecuting a case. So they have to be a police-involved case for us to come in and do that assessment. However, all cases are properly evaluated in the ER. What do victims of strangulation feel when they're being strangled? At first, they can't believe it. It's an out-of-body experience, is how they described it. All of a sudden, they realize it's happening. And that they can't breathe. Sudden that fight or flight reflex kicks in and they struggle to get the offender off of them, and that's where often there are injuries either caused to themselves by the victim or injuries to the perpetrator caused by the victim. And then there's the resignation phase where they resign themselves that this is how they're going to die. And the majority of them say that they were mostly concerned about the children. And if they die, is the person that did this to them the one that's going to get custody of the children? Casey Gwynn, one of the co-founders of the Strangulation Institute, says that domestic violence offenders and rapists don't strangle their partners to kill them. It's all about power and control. They strangle them to say, I can kill you anytime I want. And if you don't do what I tell you to do, then next time you might not live. This lady who was actually went to the Family Justice Center in San Diego said just that. She said that once she came out of the incident of the strangulation, she gave all of her power and control to her boyfriend because she was afraid that he would just take her life next time and she wouldn't survive it. On a continuum of violence, where would you think strangulation falls? Weapon. It's usually the precursor to homicide. So Casey Gwynn and the Strangulation Institute believes that if they would not prosecute the slaps, the punches, and the kicks of domestic violence, but focus on the strangulations, that they would be able to reduce the domestic violence homicides by about 50%. Some definitions, and you know all of these, but suffocation is basically obstructing oxygen from getting into the lungs. It can be done many ways, and one of the common ways in the domestic violence strangulation is a combination where the perpetrator is straddling the abdomen, and leaning over, strangling with one hand and suffocating with the other. And that in the early 1800s used to be called burking. So there weren't bodies available back then to use for anatomy classes. So Mr. Burke and Mr. Hare decided that they would find their own bodies and sell them to the physician who did the anatomy classes. And that's exactly how they did that. So burking is what suffocation used to be called. But if you imagine somebody sitting on your abdomen and your diaphragms can't expand, they can't travel down, and your lungs can't fill up with oxygen, and at the same time somebody's strangling you, you're struggling to breathe, and they have their hand over your mouth. And it's not uncommon. The textbook definition of strangulation is a form of asphyxia characterized by closure of the blood vessels or air passages of the neck as a result of external pressure applied to the neck. And asphyxia is tissue cells of oxygen, and that can include strangulation, choking, or suffocation. And there are three different things. There are three forms of strangulation. I used to just talk about ligature and manual strangulations. A ligature is anything that's used to wrap around the neck and apply pressure. So years ago, and probably at least half of you won't remember this, but there used to be phones hanging on the wall in everybody's kitchen. And that phone cord was the most commonly used ligature back then. Now it's anything they can get their hands on. I had one lady that was strangled by the strap of her pocketbook. We had a lady recently, which is why I included hanging, who was suspended over a shower curtain with a belt. And then manual strangulation can be one hand, it can be two hands, from the front, from the back, or it can be a chokehold. And it's important that you ask the method that will clue you into areas to look with more detail for possible injury. And I just want to point out that strangulation and choking are two different things. You choke on a bolus of food that's obstructing your airway. It's an internal event, and if you die from it, it's an accidental death. You're strangled because of somebody applying external pressure. It's an external event, and if you die from that, it's a homicide. So they're two completely different things. And when we talk about documentation, it's really important that if you're putting in quotes what the patient said, you can use choke or choking. But as medical professionals, you should use strangled or strangulation in your documentation. So these are the three articles that were published after the death of the two women in '95. These were done by an attorney, an emergency room physician, and a forensic pathologist. And one is the criminal legal issues. The one we'll talk about is the surviving victim. And the third is the fatal cases. And what they did is a retrospective chart review of 300 victims of strangulation. What they found was that 50% of them had no visible injuries. Another 35% had injuries that were there, but you could barely see them, and you really couldn't get good pictures of them. So for the purposes of showing it in court, it didn't work. Only about 15% had injuries that were clear and were sufficient to photograph. And the other thing that makes all of the first responders key in this is that only 3% of them sought medical attention. Back then, nobody knew what could happen when somebody was strangled, because they walked away, there were no injuries, they may have been fine, but they could have died days to weeks after with no visible injuries. External signs of strangulation were absent in over half of the victims, even when they were examined by medical professionals who knew what to look for. And death can occur without any external marks at all. The brain needs a continuous supply of oxygen, basic physiology that you already know. Oxygen gets into the blood. It must be able to pass through the mouth and nose, the larynx, the trachea, into the lungs. Your diaphragms have to be able to work properly without somebody sitting on your abdomen. And then oxygen is delivered to the brain primarily by the carotid arteries. After it's delivered, waste products are delivered back, and carbon dioxide and oxygen and other waste products are transferred into the blood and returned back primarily by the jugular veins. So the anatomy of strangulation clearly involves the larynx and adjacent structures. So the carotid arteries, the jugular veins. Here's a better picture. Whoa. You have your hyoid bone. People, they didn't used to think that that was fractured in non-fatal strangulation. It was only seen in patients who have died as a result of being strangled, but there have been several cases reported recently. The fingers just have to be up above the larynx, and the hyoid bone can be fractured. You have your thyroid and cricoid cartilage, you have your carotids, your jugulars, and you also have something you wouldn't think about. Your thyroid gland is in that area as well. And when we talk about the medical consequences, just remember, any of these structures can be affected. So common pathways to unconsciousness during strangulation are lack of oxygen to the brain by either the carotid arteries or the jugular veins, or occlusion of the airway, which is much more rare because it takes a lot more pressure. If the jugular veins are occluded, it only takes about 4.5 pounds of pressure. In about 6.8 seconds, the patient will lose. If the pressure is not relieved, they can die in as little as 2 minutes. When the jugular vein is occluded, the outflow is occluded, so it's sort of like a stagnant hypoxia. And if you think about it, the carotid arteries could still be pumping. So if they're pumping, and you think about it like a balloon where the jugular veins are occluded, the carotid arteries are still pumping, and the blood vessels become more and more and more engorged with blood until they start to burst. And those are the petechiae that you'll see. With strangulation, you usually see petechiae above the area of compression, and with suffocation, they can be anywhere on the body. In addition, the carotid artery can be occluded. That takes about 11 pounds of pressure. Again, as little as 6.8 seconds, they can lose consciousness, and death can occur within 2 minutes or less. Tracheal occlusion is not the norm with the non-fatal strangulations. It's more seen with the fatal strangulations. It takes about 33 pounds of pressure to occlude the trachea. However, it's still possible to be done. The handgun trigger pull is 6 psi. Opening a can of soda is only 20 pounds per square inch of pressure. The adult male handshake can far exceed what it takes to occlude a trachea, 80 to 100 psi. How do we know what we know about strangulation? This is a really interesting study. It was done in the 1940s, and usually research that was done that long ago is obsolete. This was done by the Navy, and they initially did this to determine the effects of gravity on man, on the brain. So this was done in Red Wing, Minnesota, and what they did was induce acute arrest of circulation in the human brain. They used 11 schizophrenics and 126 apparently normal males. The men that they used were inmates in the local prison. And back then, if you volunteered for research, you got your sentence reduced. So with this 137 volunteers, they did more than 500 controlled strangulations. This is what they developed to do the strangulations with, and they named it after the 3 of them. And what they did was they instructed the participants to move their eyes back and forth constantly. They had a bell that they could use to tap out, but it happened so quickly that nobody tapped out. They inflated the cuffs to 300 millimeters of mercury. And once the participants lost consciousness, they released the pressure, let them come around, and discussed what happened. And then they did it again to see if it was reproducible. So what they found was, in about 5 to 6 seconds, the eyeballs became fixated. So they could no longer move their eyes back and forth. That's why they stopped. They had blurring of vision, rapid narrowing of the visual field, so that tunnel vision. And if you think about it, it's pre-syncopal. It's pre-syncopal symptoms. And then they lost consciousness. After they lost consciousness, they had anoxic convulsions. They were generalized tonic-clonic seizure activity. They were mild and rarely lasted more than 6 to 8 seconds. They were always preceded by a loss of consciousness. And when they were brought back, when they came back to their baseline and were talking to them, they had no memory of the seizure. That's because the parts of the brain that are very susceptible to a lack of oxygen, like the hippocampus, that are responsible for formatting and storing your memories, aren't getting oxygen. And when the brain's not getting oxygen, it can't make memories. So they had visual changes, they had auditory changes, they heard a rush in their ears, that loss of memory, and some had neurologic impairment as well. About 50% of the subjects had some paresthesias. When they returned to consciousness, they appeared dazed and confused, excited, some were euphoric, some had a foolish smile on their face. So I had a patient that came in right from the scene by EMS who was really confused and really agitated. And 4 hours later, after the CAT scan was done and the CAT scan was read and they're ready for discharge, it was a totally different person. She had gone back to her baseline, and what we saw when she came in was the effects of the hypoxia or the anoxia from the strangulation. The study also found that anoxia of at least 15 seconds resulted in involuntary loss of bladder sphincter tone, so involuntary urination. Anoxia of at least 30 seconds caused them to lose control of their bowels. These are things to look for when you assess patients that were potentially strangled. So we know from stroke studies, we know from this study, that the average time from arrest of circulation to loss of consciousness in normal, I'm not sure anybody that would volunteer for that study is really normal, but the average time is 6 8/10 seconds, and time is brain. The problem is we really don't know how long it takes for brain death. There are animal studies, but there are no controlled studies in human. However, there are 2 papers, one filmed 14 filmed hangings and one that's 8 filmed hangings. And what they found correlates to the Rawson study. Unconsciousness, 10 plus or minus 3 seconds, so anywhere from 7 to 13 seconds. The anoxic convulsions were about plus or minus, about 4 plus or minus 3 seconds after that. Last respirations were 62 to 157 seconds. Very quick. This is the study on 8 filmed hangings, and the outcome of the research was exactly identical. So we also know from stroke studies that with anoxia, we lose 32,000 neurons per second and 230 million synapses per second. So think about the patients that have been in domestic violence relationships that have been strangled over and over and over. And all of the petechial hemorrhages that have occurred from the blood vessels that have burst, and all of the brain cells that those blood vessels were supplying with oxygen that died as a result of not having the blood supply. Now's a good time? Yeah. Take a break. Only because if I wait 15 minutes, then we'll be in the middle of something. Sorry. 5 minutes? So we're going to talk about the top medical consequences. Dr. Bill Smock, who is the medical director of the Strangulation Institute, he is a police surgeon in Louisville, Kentucky, and he has done a lot of research and compiling all of these articles. Okay. So one of the first medical consequences is acute death. That can be caused by compression or occlusion of the trachea, compression or occlusion of the blood vessels, and also vagal stimulation. So if you think about it, if somebody comes in SVT and you do that carotid sinus massage in the ER, if somebody's hands are in the right place and the victim is struggling, they could have a bilateral carotid sinus massage. They can brady down, they can have arrhythmias, and because of the rapid heart rate, they can have an inability to perfuse the brain until they brady down, or because of the bradycardia, they can have an inability to perfuse the brain. And this was documented in 2 articles, actually. They can have delayed death from anoxic hypoxic brain cell death, and this can happen hours to days to months after the strangulation. And these victims can appear completely normal until they start to deteriorate. They can have an acute ischemic stroke from blockage of the carotid arteries. And we already went over the statistics, but the last one was the 218 yards of myelinated fibers that you will lose per second. So Dr. Smock was at a lateral vascular restraint training with the police in Louisville, Kentucky, and he witnessed one of the police officers, who was actually the victim, have stroke symptoms 10 minutes after he was released from the lateral vascular restraint. It was also reported by a Florida police academy, stroke symptoms after the chokehold. They can have delayed cryptogenic strokes, so strokes that they really can't find the underlying cause for. And again, these can occur months to years after the anoxic brain damage. They can have acute anoxic encephalopathy from brain damage to the blood flow to and from the brain, or both. They can have brain damage from decreased oxygen levels. And that cytotoxic cerebral edema can occur within seconds to minutes after the event. But they can also have delayed anoxic encephalopathy. Can appear completely normal until they develop these symptoms, days to weeks after the strangulation. They can develop blindness, movement disorders, pseudobulbar paralysis, paralysis of the lips and tongue. They could, if they have that, they could exhibit problems with speech, problems with swallowing. And again, they can appear completely normal until they manifest with these symptoms. They can have cervical spine injuries. They can have injuries to the body of the spine. They can have injuries to the ligaments or to the spinous processes. I had a lady that, because of strangulation, had a tiny chip fracture off of one of the bodies, but that's the only one I've seen. And this is more common when they're actually lifted up off the ground with a lateral vascular restraint, but they can also occur, we've had many that have been lifted up off the ground from the front by 2 hands where their feet aren't touching the ground. So it's really important that the proper evaluation is done by the hospital. They can have seizures, and we already talked about the anoxic convulsions. And with the onset of those, They saw abnormal brainwave activity, the delta wave that you see with deep REM sleep, but it never resolved. They can have sphincter incontinence. We talked about the 15 seconds of anoxia for involuntary urination and 30 seconds for involuntary defecation. They can have a carotid artery dissection. It can be unilateral or bilateral. There was a nurse in California that went in to be evaluated after being strangled by her boyfriend, but she waited 6 days. There were no visible injuries. Her raspy voice was gone. She said she had it initially. They did a CAT scan, the CTA, CAT scan with the dye injection, and what they found, she had bilateral carotid dissections. Women can die days to weeks after from this. They have reported strokes up to a year and some later. There are at least 6 or 7 papers written about this, case studies. They can develop a carotid artery hematoma from leakage of blood into the surrounding tissue. And they can rupture and can cause rapid death days to weeks after strangulation. Airway swelling. You can have pharyngeal, supraglottic, subglottic, and laryngeal edema. They used to say up to 36 hours after strangulation. There was one study that said up to 36 hours. The swelling can continue. Now they're saying greater than 36 hours. I had a lady come into the ER after being strangled, but she didn't come in for 48 hours. So we did her CAT scan and we did all of her studies, and she was fine. We discharged her with good discharge instructions, which is really important. She came back 2 days later, 96 hours after the initial strangulation. She had so much swelling that she couldn't even swallow a sip of water. It came back up through her nose. So it can progress for longer lives. And that's what's one of the things that's really important to tell these patients when you go to pick them up. They can have thyroid storm because of the thyroid gland, compression of the thyroid gland, resulting in thyrotoxicosis. We have one at GBMC that we're researching now for possibly writing up the case study that came in with elevated hormone levels and tachycardia. They can have vocal cord paralysis from the recurrent pharyngeal nerve, recurrent laryngeal nerve, and that can be temporary or it can be permanent. They can have the fracture of the hyoid bone, and it used to be thought that that was only seen in fatal cases, but now they're realizing that non-fatal strangulations also have hyoid bone fractures. They can have fracture of the thyroid or cricoid cartilage. From the pressure being applied, it takes significantly more pressure. To fracture the thyroid cartilage takes about almost 35 pounds of pressure, and almost 46 to fracture the cricoid cartilage. And that can lead to a life-threatening airway obstruction. They could have difficulty swallowing, painful swallowing, or inability to swallow. That can be caused either by the fractured hyoid bone, cricoid or thyroid cartilage fractures, a hematoma, or just that soft tissue swelling in the area. We're very fortunate at GBMC where we have an ENT clinic. And when we started with the ENT, residents got really excited about it, and they developed criteria to call them in for these cases. And they will come in and they will do direct laryngoscopies in the ER to evaluate patients who have been strangled and have raspy voice and things like that. And the most common, I think, is some swelling of the vocal cords, some edema. They can have a hypopharyngeal rupture, In one case, and you might see some subcutaneous emphysema there, but in one case there was actually a pneumopericardium from a strangulation-induced hypopharyngeal rupture. Tinnitus is the one thing that drives them crazy because the ringing in their ears is bad enough during the day, but when they go to lay down at night and there's silence and all they hear is that ringing and they can't sleep, often that is one of the things that brings them in to be evaluated. We've referred several of them to the Brain Institute at Sinai. There's nothing, once they're evaluated to make sure there is no aneurysm of the carotid artery resulting in nerve damage, there's nothing they can do for it. It could take days, it could take weeks, it could take years for that to resolve. Acquired glottic and subglottic stenosis from damage resulting in scarring. The problem with this is domestic violence victims often do not follow up. This is caused by scarring. You don't see this initially. So unless they continue to have problems and come in for their follow-ups, rarely do we see this. And obviously, post-traumatic stress disorder. The emotional stress caused by repeated trauma of domestic violence, day after day, year after year, that goes on for long periods of time. They can have long-term effects psychologically. They can also have problems sleeping, impairment in memory and concentration from brain cell death, depending upon what area of the brain it is. But they can also be from PTSD. They can have a miscarriage. It's difficult that the strangulation caused the miscarriage. I had one lady that was pregnant with twins that miscarried one of her twins the day after being strangled. And it is documented that it happens, but they haven't been able to attribute it to the strangulation. And then mental health problems. Is that from the brain cell death, the damage to the brain, or is that from PTSD? It could be either. So I want to talk about documentation. The first goal is to identify patients who have been strangled. And that we found to be the hardest part. Because if you ask somebody if they were strangled, they're going to tell you no. Because they think of strangled, if I was strangled, I'd be dead. And I'm not dead, so no, I wasn't strangled. So you have to ask them in a way that they would understand. Did somebody choke you? Or even did somebody put their hands or something around your neck and apply pressure? Then when you identify the patients that have been strangled, you can move on. The history is really important because you want to ask the mechanism of the strangulation. Where were the hands? Where was the pressure applied? And then you want to do a thorough assessment and thorough written documentation. The rest is what's done by the ER when they arrive. I want to play a video and talk a little bit about why victims of trauma, victims of sexual assault or strangulation might not be believed.
What time did you get back to David's flat? What time? Some of us have had more years than others.
I'm in my prime, I'll have you know.
That would be right.
Today's session is about trauma. The latest in brain science will help you in your work. I'll start with a tour of the parts of the human brain. The reptilian brain maintains basic bodily functions. The limbic system is also instinctive. It deals with fear and pleasure. For example, if you pat a dog, it senses pleasure, and without thinking, wags its tail. The neocortex is the site of logic, imagination, planning, and control. It's more sophisticated, but because it's conscious, it's slower than the older parts of the brain. The amygdala is a key part of the limbic system. It has one job, to sense danger and set off the alarm. When it's a matter of survival, the primitive parts of the brain override the conscious part. There are three possible survival responses: fight, flight, or the one that people don't think of, freeze. When the alarm goes off, blood and oxygen are diverted to muscles, body, and all systems that are not crucial to survival are switched off. Normally, the job of the hippocampus is to file memories so you can retrieve them later, but in times of memories, which makes it harder to gather evidence later on. Instead, the hippocampus switches to pumping cortisol in pain, so we can focus on survival. Example?
A farming accident where a man carried his own arm for a mile without feeling any pain?
Yes. It's an evolutionary safety mechanism which is fast and instinctive. It's our body's very clever way of protecting us. To recap, an example of the three parts of the brain working together. You're standing at a bar. Your reptilian brain is keeping your heart beating. You're enjoying the pleasure of a nice pint with your limbic system. You're using your neocortex to work out if there's time for another before the last train. What could happen to make the amygdala kick in? What if this happened? The way you'd respond would depend not on your logical brain, but on your instinctive brain. Being glassed in a bar would be a traumatic experience. Who can give me another example of an event that can cause trauma? War?
Rape?
A car crash? Good, yes. Trauma occurs when a person is overwhelmed by something beyond their control. The survival brain takes over the rational brain. It can lead to post-traumatic stress disorder, PTSD, with symptoms that last at least a month. Vicarious or secondary trauma is something you may experience if you deal with incidents such as rape or sudden death, or think of Lockerbie, Dunblane. You're not superheroes. Having a brain makes you all vulnerable to secondary trauma. It's important to understand that when trauma occurs again and again, it can become complex PTSD, such as in domestic abuse or child sexual abuse. The alarm system in the brain becomes jammed. Memories are stuck in the limbic system, so a trigger can set off the alarm. A colour, a smell, a sound, a sensation. Now, the indicators of trauma. What should you be looking out for? Depression. Crying a lot? Yes, that's one response. And at the other end of the spectrum, total numbness.
Nightmares? Flashbacks?
Stress. Good, yes. And then you feel sick. Also, shame, feelings of guilt, inability to enjoy sex, social isolation, triggers. People often feel overwhelmed by the symptoms of trauma. This can lead to using alcohol or other drugs to block out memories, or self-harm, or dissociation when a person's mind detaches from reality. Indicators can be specific to the type of trauma. Say, dental problems, when someone who is orally abused avoids going to the dentist. A victim of abuse might bond strongly to her abuser. This is known as traumatic bonding, or Stockholm syndrome. When a person's normal recording of memories doesn't work. Can you recall any times you've seen that symptom?
What time? I don't know.
A traumatized person not seem like her usual self, or maybe hypervigilant, on edge, or being startled by everyday things. Everyone is different. You never know what impact trauma will have. Symptoms can change from day to day. So what does all this mean in practice, in your job? A traumatized person's brain is protecting them, but that normal human response of self-protection can get in the way of evidence gathering. The US military has developed new trauma-informed interviewing techniques that you can use to work around this. Research shows that if someone seems vacant, they could be distracted by their traumatic memories. Try to ground them by asking a simple, non-patronizing question such as, "Are you thirsty? Do you want a glass of water?" This can help bring them back to the here and now. Don't expect a logical, linear story. Ask, "What can you recall just now?" Find out what the victim physically felt, or so. Working this way, from the instinctive sensory parts towards the logical parts of the brain, you'll get more results. In conclusion, 4 things for you to take away. Trauma response is the brain in survival mode. Repeated abuse can make trauma symptoms worse. In response to trauma, people will behave in unexpected ways. Remember, trauma is a normal human response to abnormal events.
We know that you've gone through a really painful experience, but we need to take a statement to understand what happened on Saturday night.
Are you able to tell us anything that you remember about this flat? Anything at all? A dog? Barking?
Are you able to remember any physical sensations or feelings that you had?
Cigarette smoke. Can smell it now. What was through your mind? I couldn't understand it. I just couldn't move or even scream.
To freeze is a perfectly normal response. So you start with the memories, you don't start at the beginning. You have to engage with feelings to get to the facts.
Makes sense. Check you, Professor, getting all sciencey on us.
Well, if it gives us usable evidence.
There's life in the old dog yet.
Right.
So, a patient that you have picked up that's been through trauma, if you think about it, taking a piece of paper and tearing it up into lots of little pieces and throwing it up in the air, and all the pieces land on the ground, and those are their memories about what happened, and they're trying to pick them up and put them together to put together what happened. They don't pick them up in logical order. So think about all of the patients that you've brought into the ERs where they tell you one thing, and then they tell the charge nurse another thing, and then they tell the primary nurse another thing, but are they not telling the truth? And that's what we initially used to think. Or are they bringing up the memories in the order that they're remembering them? So what they tell you is very important to document, because what they tell you may never be said again, and it might be an important piece of the puzzle about what happened to them. So I disagree with the order of the slide. I would initially say, how do you feel? Where do you hurt? Those kinds of questions. And you'll get more information. So your documentation guides your exam, but it also helps with the investigation and prosecution, and it refreshes your memory, because these cases often don't go to court for a year and a half down the road. And you're not going to remember what happened with that patient when you get a subpoena to testify a year and a half down the road. So you can pull up your records, and this will refresh your memory before you go to court. You want to get a very detailed history Describe how it happened. 1 hand, 2 hands, ligature, a forearm. And then you want to ask, did they have problems with swallowing, with breathing, any nausea and vomiting, any loss of consciousness? And I have for you, I gave out the handouts from the Strangulation Institute with all of the signs and symptoms you can see for the adult with strangulation. Key things are incontinence, changes in vision, things like that, and loss of consciousness. And because our state's attorneys now have also been trained to understand the significance of these symptoms, and now they will push for a felony assault and they will push for an attempted murder based on the documentation, based on the questions that were asked and the answers that were given that can attest to the severity of the assault. Does the history support occlusion of blood flow or occlusion of the airway? I couldn't breathe. Yes, it does. I saw spots, or I saw flashing lights, and then everything went dark. That was the pre-syncopal things that they were seeing, and then they passed out. I heard roaring in my ears. I passed out. I urinated on myself. I had a seizure. All of these support occlusion of blood flow or occlusion of airway. And if the answers to these or to any of these are yes, the assault should be a felony based on an anoxic injury to the brain. When you assess, you want to know either during or after the strangulation if any of these symptoms were present. The coughing is something that you won't forget. It's not a normal cough. It's like a cough where they're constantly trying to clear their throat. The neck swelling, the dysphagia, the vomiting, sore throat, lightheadedness. When you ask them about voice changes and you hear that raspy voice, don't assume that that's their norm, because they may have a normally raspy voice. Ask them if their voice sounds different to them. And then you can say, yes, their voice sounds different to them, and it sounds raspy to me. Neck pain, dyspnea, memory loss. Again, that points to that loss of consciousness. Weakness and numbness of extremities. I've only had 2 patients, and I've seen probably 250 unilateral weakness after being strangled, which resolved in a few minutes. Ask them what they saw and document in quotes what they tell you. Their vision began to narrow. They saw stars. They saw the room go black. Blurred vision. All of these can be documented as signs and symptoms of strangulation based on that Rawson report. We use that all the time when we testify for things. How did you feel? And document what they tell you. Fuzzy, dizzy, saw stars. Whatever they tell you, just put it in quotes. Look for injuries that were consistent with the method of strangulation that they tell you. But does a lack of injury indicate that she was not being truthful? Now you know, no, it does not. Strangulation can induce loss of consciousness in 6.8 seconds with an anoxic injury to brain cells seen, documented on an MRI in less than a minute, and death within 2 minutes. Some of the other symptoms are neck pain and sore throat, very common. Actually related to the blunt force trauma. Breathing changes or difficulty, very common. Now, you want to find out if it was psychogenic or does she have an injury? So she needs to come in to be evaluated. Was there pulmonary edema? That can occur up to 2 weeks later from the pressure changes trying to breathe against that blocked airway. Voice changes, they say up to 50%. I say it's more like 75%. That hoarse or raspy voice is very common. I've never had an inability to speak except for one time, and she couldn't speak because her throat hurt too bad. That constant throat clearing cough, caused by either laryngeal injury, swelling, bleeding, and the voice recording is something we recommend to the police and follow up with it. They can have swallowing abnormalities, pretty common. They can have difficulty swallowing, painful swallowing, more common painful swallowing than anything else. And again, from a laryngeal injury. And that may be immediate, or we talked about the progression of the swelling over a period of time. It can also be a delayed problem. Other symptoms of asphyxia or hypoxia are the mental status and consciousness changes. So lightheadedness, dizziness, that memory loss of consciousness, and that seizure activity, and behavioral changes. Early behavioral changes, restlessness and violence, hostile towards the officers or EMS at the scene. I know you never have anybody that is hostile towards you. But if they're like that and there's no history of anything and it was an assault and there's somebody in the house that's a little suspicious, ask them the strangulation questions. Think about it. Long-term psychosis, amnesia, personality changes, and progressive dementia. There's a study going on now studying early onset dementia in strangulation victims. If you watch this, this will just show you how quickly it happens, and count the seconds. So 1, he's got the hands around her throat, 2, 3, 4, 5, 6, 7, and she's going down. Her feet are starting to drag. That quickly it happened. She's on the ground. Watch her feet. I don't know if you can see it on here, the quality is. Her feet are starting to shake, so she has the convulsions. And then security's walking up, so he literally drags her up off the ground, and you can tell that she's a little not with it, maybe a little confused. And security walks up, and he puts his arm around her, and he says, you know, I told her she's got to stop drinking, we're fine. And walks away, and nothing's ever done. That's how quickly it happens. I have one more. This is an MMA fighter. Chokes out a reporter, and look how quickly it happens.
Quanto tempo vai demorar para você parar para dormir?
3 segundos.
3 seconds.
Oh, it takes about 3 seconds?
A little longer.
Well, to the normal person.
1, 2, 3. It's really closer to 7. Look at his eyes start to roll back. He's out. That's how fast it happens.
He's out.
They confused. Doesn't know what happened, doesn't remember it.
Okay, the question, do you dream with Gina or Chris?
This is true with MMA World.
Happens very quickly. And when somebody's being strangled and they lose consciousness that quickly and the pressure isn't relieved, they can die very quickly. So what are the signs and symptoms you might see? You might see abrasions or scratch marks, or what we call linear abrasions from the fingernails. You might see curved scratch marks, curvilinear abrasions, which are fingernail marks. You might see petechiae, just over the face in strangulation or generalized in suffocation. You might see contusions or bruises. If you look inside the lip, you might see abrasions or contusions from the lips being held against the teeth, and you might even see an outline of the teeth. You might see ligature marks. So these are basically claw marks getting hands off of a neck. This is a bruise behind the ear, which I always thought was from the top finger when somebody's strangling someone, but the insertion of the sternocleidomastoid muscle is on that mastoid process. And in the struggle, as fibers and blood vessels are breaking, the blood will pool behind the ear. That's a thumbprint bruise. Very common, don't forget to look under their chin, very common to have bruising or scratching under the chin, because if somebody's got their hands around your throat, you're going to instinctively lower your chin to try and protect your airway. It would be really nice if everybody had this. We wouldn't have any problems with prosecuting. So it's usually the first 3 fingers that have enough pressure behind them to break blood vessels. The pinky usually doesn't. It's hard that as blood vessels were breaking, there was no room under the fingers for the blood to leak. So it leaked to the area of least resistance and outlined the fingers. You could see the blood there. And the center part of each finger is called central clearing or sparing. That's where the pressure was being applied. And somebody that was strangled like this probably had one on the other side, which was the thumb. But it's never this easy. These pictures they do on the multiple areas of redness and scratching. Here's another one from multiple incidents of strangulation. This is one that we had, the red marks, the erythema, and the bruising under the chin incident. Here, the same patient, just with a ruler for measurement. This is somebody that was strangled several times, and if you look at her face, I have 2 more pictures of her, it looks like she has bad skin. A lot of that is petechiae. So if you're not sure, ask them if they're broken out, if their skin is usually like that, and even show them a picture of themselves. Everybody carries iPhone. Put it on photo. Don't take a picture, just turn it around to look at them and let them look at it, and they can tell you. Petechiae. This is one petechiae in the medial aspect of the sclera. This was due to blunt force trauma, not strangulation, but I just grabbed the picture because you could see, whoops, because you could see the petechiae in it. Does anybody know what else causes petechiae besides strangulation? Sepsis. Yes. And what did you say? Violent coughing, violent vomiting, scuba diving, childbirth. There's all kinds of things. Petechiae around the eye. It almost looks like freckles. If you're not sure, just ask them. You got some petechiae up in this area. This lady is the same lady from before. She had petechiae all over her face, as well as behind her ear. Dr. Dean Hawley, who is the forensic pathologist that did these studies with the Strangulation Institute, said that he has never done an autopsy where he has seen just at least one external petechiae where he didn't see many, many more in the brain. So if you even see one on the surface, she's got many, many more in the brain. Again, can occur anywhere above the point of strangulation, but if you take a look at this, there is a clear line of demarcation where the pressure was applied around her neck, and above it she's got fluid petechiae. This could not have been caused by anything other than strangulation. Subconjunctival hemorrhage, this is another thing that brings them to the ER. There's nothing to do for it. It takes time to resolve. The only time we ever refer them, and I think it's only been 2 patients where they've had vision changes, so we've referred them to ophthalmology, but it looks bad, and it really bothers them. And they're worried about everybody seeing it and asking questions, so they usually come in for something like this. This is one of our patients with all of this subconjunctival hemorrhage. The other thing is venous congestion. So not if their eyes are red from and they're rubbing them and tearful, but venous congestion is the blood vessels engorge with blood just before they burst. And if pressure would have been applied for a few more seconds, you would be looking at petechiae instead. So getting to the scene quickly and seeing that, that's a really good thing to document. And petechiae can be anywhere. Soft palate of the mouth, back here. And they can be, you really can't see it well in this one, on the uvula as well. So you kind of have to look everywhere. And in the brain, obviously. And remember, every single petechiae you see here was supplying brain cells, was supplying neurons with oxygen. And these neurons now are dead, and they don't regenerate. They're lost. And ligature marks. The other thing is the urination. So you need to ask somebody about it, but you need to normalize it. People who were strangled often lose control of their body functions because it's really embarrassing to them and they don't want to talk about it. And often, they've changed their clothes before you get there. So when you ask them if they changed their clothes, because in Baltimore County, crime lab will come pick up those clothes as evidence. The other thing is to make sure when it happened. Did it happen before you passed out because you were just really afraid, or did you come around and realize that you had wet yourself? There's a definite distinction that's important there. The main thing that I'm really concerned about is scene safety. You're really at risk when responding to domestic violence. Now, I know police are dispatched with you, so it's not the known domestic incident that worries me. It's the lady who fell down the stairs and has a hip fracture, and the guy hovering over her that is saying she's fine, and answering all the questions for her and won't let her answer questions. And the police aren't there because it didn't come out as a domestic. And if you're really leery, you have to think of yourself. Back up and call for police. Because there have been a lot of incidents lately with police involved, shootings from domestic violence. And you don't know when you go into that house, even if it's one that you go to time after time after time, and you roll your eyes when you get the call and you say, well, they're at it again. And then that time may be different because she may have said, I'm leaving you. And he may have thought, well, if I can't have you, nobody else will. So he kills her, and he's waiting for the first person to come, assuming it's a police officer, for a suicide by cop. So you just never know with these domestic incidents what you're walking into. I think this is probably the most serious, most dangerous call that you can have. The other thing is, remember that domestic violence is not a mandated report in Maryland. The reason for that being is if you report, if you go to the house and you tell the police, you call the police and say, hey, I have a domestic, he beat her or he strangled her or whatever happened, and you take her to the hospital, they may go and arrest him. And he may be released on his own recognizance. And when he is, and she's released from the hospital not knowing what happened, he's going to beat the crap out of her and make her pay for telling the police. So that's one of the reasons that they prefer not to notify police, if at all possible. But again, scene safety is of utmost importance. So if you suspect anything, call the police. You have to be safe.
So if we go on a call and we think there's probable cause for domestic violence on that call, we are not supposed to call PD?
You are not supposed to report it unless they want it reported, as long as you feel safe. In Maryland, domestic violence is not a mandated report. Doesn't mean you can't, but think about that patient too, and think about their safety. There is a reason. You can talk to the patient on the way to the hospital and encourage them, but you can make it worse for the patient in the long run if you do, as long as you feel safe.
And if the patient says to you in the back of the Medicare, "You beat the hell out of me,"
do you want me to call the police? I would be happy to call the police for you. And then when they get to the hospital, report it to the hospital, and they will do more follow-up. Most of the hospitals, at least in this area, have domestic violence advocates that do safety planning, shelter if need be, if going home safe is not an option. So, yeah.
Age 8 or over age of 18, is that correct? Mm-hmm. Child abuse is
Child abuse is different, well, we can get into that. That's a whole nother thing. We'll talk.
Giving a talk on domestic violence. She works for the state about EMS is required, what's not, how to handle domestic violence. You guys have an interest to extend that.
Yeah, I would like to attend that. But again, your safety is your priority. And if it means that you have to call the police, you call the police if you're not safe. But then her safety is your next priority, and look what can happen if you do call the police. So you have to weigh it. And you have to follow your protocols as well. The next thing is assessment and treatment. You want to separate the patient. So you want to get her away from the guy hovering over her answering the questions. Get her out to the medic. Ask the right questions about strangulation, not just were you strangled. ABCs, vital signs. Assess and monitor for signs of stroke. Document and treat any visible injuries. Document all of those things that she says yes to that are on that piece of paper. Pain, shortness of breath, voice changes, visual changes, loss of consciousness. And you want to transport her to the hospital, monitoring her airway and monitoring for any change in mental status. And this is what we're talking about. They realized that they weren't hitting first responders at the Strangulation Institute, so they developed a class for EMS. And they had several groups come through. I have to say, we started training EMS in Baltimore County before they did at the Strangulation. And one of the EMS providers developed this with the word strangle. Take in the scene, make sure you and the victim are safe. Traumatized, ask about what you remember, what you see, what you feel, what you hear. Reassure the victim that help's available. And providing resources is really not your responsibility. I mean, you can, but in the hospital there is an advocate that does specifically that. Assess for the signs, document your observations. Give the victim advisal about delayed consequences if they want to sign an AMA and decline going to the hospital. Talk about a loss of consciousness, lapse of memory, and encourage medical attention. One of the other group of paramedics came up with a different mnemonic. I kind of like pieces of each. So if you're interested, you can develop your own. So when you document, you want to document what the patient says in quotes, but then you want to document what you say. You can say, she said he choked me, but you say, patient was strangled. Patient was strangled by the father of the baby, and the mechanism, using one hand from the front, or a chokehold, or two hands from the front. And you can use victim of non-fatal strangulation or victim of near-fatal strangulation. I have a friend that works in another county who had a 12-year-old who was sexually assaulted by mom's boyfriend and then strangled. Mom came home, saw what was going on, saw the child being strangled, and the boyfriend ran out the front door. When she saw that, she saw his feet moving. He was seizing. And when she went over to the child, he wasn't breathing. She gave him mouth-to-mouth. He came around quickly, and the child is fine. But that was a near-fatal strangulation. I wouldn't even call that non-fatal. And how would you document that someone lost consciousness? That loss of period of time. So one thing, first I remember I was sitting on the bed holding the baby, and then the next thing I remember I was on the floor, and the baby wasn't even in the room. There was a period of time lost while she was unconscious. Bowel or bladder incontinence, an unexplained bump on the head. And if there was a witness that saw that seizure activity, or eyes rolling up. The other thing I think is important to document is, we always document pain scales, and we're really good at that. Document a pressure scale. So on a scale of 0 to 10, how much pressure did you feel when the hands were around your neck? And it gives the patient's perception of how bad it was. And I encourage transport and to the hospital. See that medic? So encourage transport to a medical facility. If anybody works in a hospital, I'll be happy to give you a copy of this. This is the recommended treatment for evaluation of patients that have been strangled. Encourage them to seek medical attention. We did a pilot project with the alternate light source several years ago. So an alternate light source can filter out certain wavelengths of light. Forensic nurses have used them for years because using the alternate light source, body fluids fluoresce. And if we're doing a sexual assault exam and something fluoresces, we swab it and collect it as evidence, and hopefully it's DNA. Blood under the skin does not fluoresce, it absorbs light and provides a contrast from the surrounding tissue. So we started with this several years ago, and now we use it on a regular basis. This is what the old one looked like. This is the new crime cam. And this is an example. You can barely see something here. It was very tender to palpation. And look at the difference. You can't see it on the screen as well with the alternate light source. You really can't see this well on there. But they're right over here. And with a light source, you can see it much better. So I just want to talk just a couple minutes about pediatric strangulation. There were 2 recent webinars from the Strangulation Institute because more and more people are starting to realize that yes, it does happen to the pediatric population. The problem is you can't take the adult literature and apply it across the board to the pediatric patient. And most pediatric research is on accidental hangings or suicidal hangings. One investigation reported 70 out of 10,000 admissions at one hospital over a year. 70 kids were strangled. That's a pretty high number. Another center reported 32 of 10,000 over 9 years. The problem is there's limited data available. But we realize now that it's more common than was previously recognized. There are a lot of challenges. It's more likely to be underappreciated by law enforcement, medical providers, prosecutors, judges. I spoke to a pediatrician who I suggested screening children more often for strangulation. And the response was basically that it doesn't happen to kids, but it does. They're less able to protect themselves, and it's common to be missed or underestimated because just like adults, the assumption is that 50% may have no visible signs. And because of their age and their development, they might not be able to articulate what happened to them. Delayed presentation is common without current symptoms. So what do we do if it's that delayed? Often with child sexual assault, it's a delayed report because who's doing the assaulting? It's often the primary caregiver. It might be mom, it might be dad, it might be Uncle Bob, it might be a teacher. But especially if it's in the family, they may say something to the kid like, if you tell, they're going to take you away from us. So often, child sexual abuse is not reported until later, until the kids are older. The same thing with strangulation. A friend of mine in another county had a three-year-old that was in daycare that mom dropped off, covered the marks, the bruises from strangulation with makeup. And later in the day, they recognized that there was bruising on the skin as the makeup started to rub off, and they called police and CPS. So it does happen, and I think we're missing a lot of them. Symptoms could be very mild or very severe, and they can die from it. Some symptoms that you see in adults might not be important in children. If you're dealing with a kid in diapers or recently potty trained, if they have either urinary or fecal incontinence, you can't attribute that to strangulation. And they might describe symptoms differently than adults. They might present with hypoxic brain injury resulting in seizures, altered level of consciousness, altered mental status, respiratory depression. And when they're evaluated in the ER and they have that sepsis workup and they have that spinal tap and everything's negative, I still don't think they think about, was this child strangled? It's not something we think about yet. It's still really in its infancy. Respiratory distress due to acute lung injury, ischemic stroke symptoms from carotid occlusion or dissection. Airway considerations in the pediatric patient are different. Their airway, they have smaller nasal apertures, so they can more easily be obstructed by secretions. Their airway is a little bit more cone-shaped. It's much higher in the neck. The cricoid cartilage completely circles it in the infant, and it's not documented that it happens, but the author in this study suggests that edema could severely compromise the airway in the pediatric patient more so than the adult. And then their larger head relative to their body size makes them susceptible to airway obstruction. Cartilage is less calcified, less likely to find fractures, and the pressures to occlude are likely less, but we don't know. They might be at greater risk of pulmonary complications, cerebral edema, and especially late cerebral edema and severe hypoxic ischemic encephalopathy. So the mechanism may be manual chokehold or ligature, but it's easier to lift kids off the ground by their clothing, and their clothing could become a ligature. And what they're thinking now is that the motivation is different. So in the adult strangulation, it's usually a male perpetrator, and it's all about power and control and getting and maintaining power and control. For the child, it's usually a female perpetrator, and it's out of frustration for that loss of control. So the mechanism or the motivation is different. And symptoms reported. They can't report them. They might say things like, I talked like a duck, for that raspy voice. Or I saw sparkles in my eyes from the pre-syncopal things that they might see. Or I fell asleep because they passed out. So you might need to ask them different questions or things that you wouldn't think about documenting that they might say. You need to think really closely and document those things because they might not say them again. They can have, I'm short on time, I'll go quick, they can have the same external injuries. They can have petechiae, vascular congestion, bruising, defensive marks, abrasions, injuries elsewhere. And you have a pediatric one as well. They are basically the same. Severe delayed effects could be vocal cord paralysis, and it can be unilateral or bilateral. Hypoxic ischemic encephalopathy, cerebral edema, and so on. Basically the same as the adult, no different. And death. And Casey Gwynn from the Strangulation Institute came out with a paper that it's not just one bad thing. So when you are at the scene with a child and you're there for sexual abuse, head trauma, it's rarely just one bad thing. So the abuse of head trauma, they may have grabbed him by the neck and strangled him and shaken him back and forth so hard that they have abuse of head trauma. Think about checking out for strangulation. Other forms of physical abuse, family violence and dysfunction. Parents who don't have the knowledge of how to handle or how to raise children, and as a result, and out of frustration, they become violent, and they become violent to the children. And the problem is that there is no consensus of opinion even as far as what exams to do for the child, because it's a whole different ballgame when you have a young child who you suspect was being strangled. Trying to get that CAT scan with contrast usually involves sedating as well and adds another thing into the mix. So there really is no consensus of opinion yet. It's still very new, and more research will be coming out. I want to briefly talk about the choking game. The last press release was 2008 by the CDC, 82 youths, 87% males, most fatalities from 11 to 16. Signs to look for are discussion of the game, and there are pages of different terms you can use. Bloodshot eyes, marks on the neck, severe headaches, disorientation, and the other symptoms we just talked about, especially after spending time in the room with the door shut. And items tied to the bedroom furniture or doorknobs, or unexplained presence of things like dog leashes, stuff like that. Physical exams should include vital signs, including a pulse ox, survey of all skin surfaces, looking for petechiae, bites, bruising, and so on, and assess for intraoral injuries. If they're admitted, we want to get serial measurements of the neck every 10 to 12 hours, looking for swelling. And just the basic same assessment that you do for adults, respiratory distress, stridor, eye exam for petechiae or redness, neuro exam or presence of irritability, somnolence, behavioral changes or seizures. And that's it. Question?
So the one that's neck pain, like neck pain, I wouldn't want to be putting collars on these types of patients, right? I feel like that would cause a lot of trauma and it's like different.
I think, any suggestions? I think it depends on the mechanism that they explain to you, first of all. So if they were lifted up off the ground that way or this way, I would think I would collar them anyway, because that's what would make them more prone to the C-spine injuries. Agree?
Yeah, especially if
Yeah.
having neck pain.
Yeah. Anything else?
Around the trach really, because it's more jaw support and pressure on the rear, so.
I'm thinking more about like psychologically. Yeah.
Well, that's true. Well, right, they may very well resist. That is, pretty much mobilized with, pillows or blankets or old school mobilization.
I'm assuming with the potential to have complications later that we should not allow patients to refuse, if at all possible?
If at all possible, you can't. And the other thing, with documentation, refuse is not a word to use, it's declined. Sorry, it's the legal part of it.
But just in their interest,
right.
EMS supervisors.
Best to have them go to a hospital to be evaluated and explain what can potentially happen to them. What could the complications be, despite the fact that they feel perfectly fine right now, and especially if they're pregnant. And if they are pregnant, make sure they go somewhere where they can have fetal monitoring as well.
Did I understand through the explanation of the word strangulation that there is some resistance to using that in a BLS or an ALS report?
No, you should use it.
Use the word strangulation?
Yes, you should not use choked unless it's the patient's words. You should always use strangled or strangulation, because that's what it is.
Okay, I was just thinking from a legal standpoint, if you bring this patient in to the receiving nurse and you said, they ask, well, what do you got? And you run this.
They should know.
Signs and symptoms. Where does that put our BLS crew if it turns out to be something other than strangulation that's written in an EMS report?
You can't write a diagnosis, but you can write strangulation is not necessarily a diagnosis, it's kind of interchangeable.
It's a report of.
Right. And anything the patient says, you can always use the patient's words.
And if they tell you, he put his hands on my neck and applied pressure, you can use in your own words, that's strangled.
But it's actually better to write in quotes.
Yep.
Patient stated, in quotes, he put his hands on my neck and applied pressure, unquote. Yep. That's perfect.
And that gets you...
And that's all you need to write.
Anything else? Thank you.